It's something we've been talking a lot about in our team at OHSU, and we're kind of writing up our early experience with peds endocrinology and pelvic floor physio and us as surgeons, and kind of really collaborating to put out, this is our early experience with this group of patients, and this is what's working and what isn't. Because there's just so little that's really been talked about or described. And as more and more vaginoplasties and gender surgeries being done, and as more suppressions coming through, like it's coming right at us. So as a field, like we all kind of need to be aware and start thinking about how we can optimize these outcomes. And it's challenging because there's this question of how does that factor into consent when you're consenting someone for pubertal suppression? And there likely is some effect on downstage genital surgery, but you don't know if an individual is going to desire genital surgery in the future or not. And then it's also hard to have that conversation with someone that maybe hasn't went through puberty or ever engaged in sexual activity. It's a really tricky thing. And when it comes time to actually do surgery, if an individual does go through suppression and ultimately is in their latter teenage years and wants a vaginoplasty, not only are you facing the struggle of not having a lot of tissue to work with, but that tissue hasn't been under the influence of testosterone, which definitely affects some things. And then a lot of patients, just from psychosocial issues and the dysphoria that they're experiencing, or just blatant transphobia in society, may have not had the opportunity to have a sexual partner. And more often than not, there's been almost no genital engagement in terms of self-stimulation or masturbation. So then trying to assess things like erogenous outcomes after a surgery when someone's never had an erogenous experience in their life is incredibly difficult because they don't really have a baseline to compare it to. And then, post-operative care, anyone knows that's seen a post-operative vaginoplasty patient is really intense. And we're kind of asking someone that is younger and hasn't really engaged or done much with their genitalia to all of a sudden do this like really aggressive relaxation for dilation. And it's just a huge ask. So we're finding that to be a barrier, almost more so than, yes, the surgery is technically challenging and demanding, but I think we're developing pretty good strategies to deal with that. But what we really need is like a robust support system. And I think there's going to be a huge role for therapy peri-operatively in terms of even preoperative genital engagement, trying to have those conversations, preparedness, readiness, support through that postoperative protocol, because some of the early challenges are getting someone to successfully dilate that's never had to engage with their pelvic floor musculature and is maybe 17, 18 years old. It's hard.
Absolutely. I was talking to a colleague the other day about that, and because she had a patient who was an adolescent and underwent pubertal suppression and had vaginoplasty, and it just had me thinking, when we undergo pelvic floor training, and I'm not a pediatric pelvic floor specialist by any means, but there's still this ongoing conversations regarding the ethics of doing an internal assessment on an adolescent who's never had any sexual activity or even self-stimulation, and do like their first experience with their anatomy being from this provider or from dilation, which the symptoms associated with that. So it's just, yeah, there's a lot of layers to consider.
No, there is, for sure. And I think we're all having very open conversations, and with patients and families too, trying to figure out what is the best thing. Because long term, we want people not only to have relief of dysphoria, but have like a functional and satisfactory, great sex life too. And we're trying to think like, what can we do ahead of time? Like, are things like encouraging genital engagement preoperatively, is that a bad thing or a good thing? I don't think we really know yet in terms of what's the trade-off with physical anatomy versus, exacerbating dysphoria. It's a very complicated issue, and I'm not sure there's like one answer for everybody. But I think definitely something that we're going to learn a lot more about in the next 5 to 10 years as we're doing just increasing numbers of these cases. And I think that applies for all of y'all doing pelvic floor physio too. So I'm sure we'll be in close communication.
Yeah, it will be fascinating to see how it unfolds. I hope that we see more research rolling out regarding assessing the efficacy of different interventions. You mentioned, how intense post-op care is after vaginoplasty, and that kind of is a nice segue into my next question about how it's becoming increasingly common for folks to opt for a vulvoplasty, I believe is how you referred to it, otherwise known as a minimal or no depth vaginoplasty. What trends do you notice in terms of how this